History of presenting illness. Patient was apparently all right 6 months back when she started experiencing intermittent fever with chills not associated with night sweats. Temperature was never documented, but it used to increase during evening hours. It was not associated with any rash. She noticed loss of appetite and weight loss of approximately 4 to 6 kg over the last 6 months. Fever was not associated with cough, cold, loose stools, burning micturition, or abdominal pain. Patient also noticed tingling and numbness in bilateral upper limb up to the wrist and in the bilateral lower limb up to the ankle since last 1 month. However, there was no any history suggestive of slippage of footwear without immediate realization or wash basin phenomenon or painless unnoticed injuries over the limbs. No history of worsening of symptoms in night time. This was followed by bluish black discoloration of right great toe, right second toe, and left fourth toe, without history of foul-smelling discharge from the discolored toe, for which she underwent debridement and partial amputation of right great toe at local hospital from Ratnagiri. There was no history of Raynaud's phenomenon or limb claudication or only lacy rash over the foot, no history of any digital ulcer preceding the gangrene. On inquiry, patient gives history of difficulty in holding objects in right upper limb, such as difficulty in holding a spoon while eating. No history of similar complaints in other limbs. No history suggestive of proximal muscle weakness in upper and lower limb. No history suggestive of cranial involvement or bladder bowel involvement. History of recurrent oral ulcers present on palate which were painless. There was history of excessive hair loss from the scalp. No history of photosensitivity, dry mouth or dry eye or arthralgia. No history of cola-colored urine, frothy urine, bipedal edema, perioperative puffiness or reduced urine output. No history of sinusitis, epistaxis, ear discharge, hearing loss, chronic cough, hemoptysis or wheezing. No history of postprandial abdominal pain, melena, hematochezia or vomiting. No chest pain, palpitation or syncope. No history of previous thrombotic phenomenon or TIA-like episode. Coming to treatment history, 5 months back in April 2025, patient visited a local doctor and underwent a radiological investigation for her symptoms. Her HRCT chest in April was suggestive of nodules in the anterior segment of the upper lobe, left basal pleural thickening, and calcified mediastinal lymph node, for which patient was started on antitubercular treatment empirically despite no microbiological evidence of tuberculosis. There was slight improvement in the appetite, but no weight gain. The patient continued to have fever while on antitubercular therapy, for which she came to Nair Hospital in October 2025. And during ward course in Nair Hospital, patient received 1 pint of uh, PRBC transfusion. Past history, there was history of pleural effusion. Patient doesn't remember exactly, but there was history of fluid tap from the chest at the age of 4 years, for which antitubercular treatment was taken for 6 months. Menstrual history, patient attained menarche at 14 years of age. It was regular 28-day cycle with a normal flow lasting for 4 to 5 days. Patient was amenorrheic since last 5 months, since the illness was started. Family history, there was no significant family history. Personal history, sleep normal, bowel bladder normal, appetite reduced, denied any addiction, no any comorbidities. Uh, to summarize my case, a 16-year-old female with 6 month history of persistent fever, evening rise with loss of appetite and weight loss, and no clinical response to tubercular therapy. And over the course of illness, there was development of painful lower limb toe gangrene with right upper limb distal weakness, tingling numbness in all four limbs, and recurrent oral ulcers and alopecia, and a significant past history of extrapulmonary tuberculosis in the childhood. So, my differential diagnosis are, so I would like to keep my first differential diagnosis is autoimmune etiology, as considering the age of the patient and the multisystemic involvement and no any improvement on antitubercular therapy. I would like to keep systemic lupus erythematosus with vasculitis with neuritis multiplex as a first differential. Second would be systemic lupus erythematosus with antiphospholipid syndrome overlap. Third, systemic vasculitis, likely medium or small vessel vasculitis. And as the India is being endemic for tuberculosis, I would also like to rule out the drug-resistant tuberculosis with tubercular arthritis in my patient. So coming to
Rani,
examination, patient was yes, sir.
uh, so just to a single point, I don't know if others agree, but on history, whether you can have the HRCT findings so precisely mentioned, uh, did
Okay,
you get it
actually,
on the history, or it was later on that the HRCT test was known to you?
said due it. I mentioned it in the treatment history. Actually, I saw the report of previous HRCT, which was done in April, and that's why I
Okay.
mentioned it
Yeah,
because
this is not
uh,
clinical, but then I feel that you could say that a scan of the chest was done and there were findings. Patient was told suggestive of tuberculosis and tuberculosis treatment was started.
yeah, yes,
Uh, and you also mentioned that there were some painless ulcers on the palate in your history. So
yes.
how did, if it was painless, then how did the patient was aware of it and how did she complain to it?
Uh, Sir, actually, it was painless, but it used to have burning only while eating something. But otherwise, it was not painful ulcers. Uh,
Okay. Okay. Yeah. So you might want to modify while presenting that statement because when you say it was painless, then there has to be something which either the relative has noticed it or the patient has some other symptom so they can give you this history of recurrent oral ulcers. And how did you
mm,
exactly ask for the history of Raynaud's to this patient?
Sir, I asked on the exposure of cold or in the cold water, uh, was there any change in the uh, color of the fingers from white to bluish
Okay. And the patient could understand that, right?
to reddish discoloration we associate with tingling and numbness and should be
Okay.
painful. Yes, yes.
In your differentials and also in the negative history, if I add something in the history about bone pains, uh, you did mention about
Yes,
no nocturnal symptoms, night sweats.
yes, yes.
If I add a history of bone pain, would the list of your differentials change there?
Yes, sir. If bone pains were present, then I could add. I would like to add malignancy as one of my differential. As childhood malignancies like leukemia and lymphoma can have constitutional features with long-standing history. Uh,
Okay.
but
And most of the
uh,
other symptoms would also fit into. Do you think the history of the digital gangrene, the toe, ischemia that you mentioned, and the neurological symptoms, could you still fit into all those things, or they would not fit in completely?
Sir, in malignancies, sometimes hyperviscosity can have uh, gangrene due to blockage, and
Yeah, very
I
good.
think
And which other
uh,
leukemia is known to specifically have either DIC or a thrombotic manifestation as presentation?
sir, APML
Very
children's
good.
promyelocytic leukemias.
Correct. So if the symptoms can be explained to, I mean, even with a stretch, then there should be one line in your negative history so that, you have given it a thought and you have excluded it. Maybe you are presenting it in the examination method. You can mention it there. Girish, if you have anything on history or differentials, then please go ahead.
No, I think we can
Okay, we
go
can
to
continue.
exam.
I think I have a question.
Uh,
Singapore.
okay,
Hello.
Yeah, yeah, please,
Yes, sir, you are
Chengapur, go
audible.
ahead.
yes, sir.
So,
Yes,
a
sir.
young
Uh,
female who presents with fever, weight loss, and gangrene, why isn't the primary vasculitis a differential?
Sir, it could be primary vasculitis. There was no any history of renal involvement. and no any upper respiratory tract involvement. So I've mentioned in my negative history. So it
So
could be, sir, but
what are the features of a medium vessel vasculitis? What are the clinical features of a medium vessel vasculitis?
so medium vessel vasculitis, it can have involvement of skin. Patient can have palpable purpuras, subcutaneous nodules, or the liver or the livedo reticularis, or in GPA there could be involvement of upper respiratory tract causing epistaxis or the upper nasal airway obstruction, or hemoptysis, or involvement of lung. Can have the severe manifestation can have DAH, involvement of kidney. It can have in history, cola urine or hematuria or frothy urine.
So
Uh,
these are all manifestations of a small vessel involvement, not a medium vessel.
okay, I've kept my third differential as
Okay, okay,
systemic vasculitis. Yeah.
sure. And how do you explain that effusion that was stabbed at the age of 4?
Sorry, sir, I could not hear you.
Pleural effusion that was
And
stabbed.
sir, at the age of 4, she had the effusion. She vaguely remembered the history, but the relatives said that there was a fluid was tapped from the chest, and she took treatment for almost 6 months. And they mentioned about the TB, taking antitubercular drugs. So from the history, it suggests you of a tuberculosis infection in the childhood.
Okay. So how do you differentiate a
Apart
drug-induced
from that,
lupus from a normal lupus?
sir, in my patient, actually before starting of the antitubercular treatment, patient had symptoms or constitutional symptoms and other, and which were progressed. And otherwise, in drug-induced lupus, uh, those it won't have severe manifestation. It usually presents with arthralgias, serositis, myalgias, with lesser involvement of yes, central nervous system, lung, or the other major organs. And usually it resolves after stopping of drugs.
Sure, thank you.
Uh,
Which antibody you would expect positive in this case? Just a quick one before you start with your examination. Drug-induced lupus.
drug and anti-histamine antibodies.
Okay, go ahead with your examination findings. Good.
Okay. On examination, a patient was conscious, oriented, and cooperative. She was febrile with temperature of 38.3 degrees Celsius. Pulse rate was 110 per minute in right atrial artery, and all peripheral pulses were well felt. Blood pressure was 110 by 80 millimeter of mercury in right arm in supine position. Respiratory rate was 14 per minute. Pa- Patient was thin-built, poorly nourished with BMI of 16.8. Pallor was present. No icterus, cyanosis, clubbing, lymphadenopathy, or edema. On 8 to 2 examination, it was diffusely thin, short, fragile hairs with patchy hair loss. Large ulcers on hard palate, large ulcer on hard palate present. There was bilateral thenar atrophy and atrophy on the dorsum of right hand on ulnar aspect. There was right fourth and fifth fingers clawed. Right great toe, post amputation, the wound appeared dry and healed. Left fourth toe, there was clear line of demarcation, was suggestive of a dry gangrene. So this was a picture of a patient when the symptoms were started before she came to us. The right grade toe, the skin appears blackish and the overlying skin is shriveled. And this was before the amputation was done. This was the photos of her hands. On palmar aspect, there is the thinner side is little flattened, and on right hand, the fourth and fifth fingers are clawed, and on ulnar aspect on the ulnar distribute area on the dorsal aspect, there appears a atrophy of a overlying atrophy of that area. On systemic examination, respiratory system, chest movement normal bilaterally, air entry bilaterally equal, bilateral vesicular sounds present, no any adventitious sounds. Cardiovascular system, heart sounds normal in all four areas, no murmur. Gastrointestinal system, per abdomen soft and non-tender. On CNS examination, higher mental functions are normal, cranial nerve normal, motor system, nutritional or in nutrition, there was bilateral thinner wasted, right more than left. In the wasting of on the dorsum of the right hand on the ulnar aspect, power was 5 by 5 at all joints, but right hand grip was weak and the ulnar innervated muscles were weak on examination. Deep tendon reflex is normal. Plantar flexile bilaterally. On sensory examination, light touch, crude touch, pain, temperature lost up to the wrist and up to the ankle by 30%. Vibration sense lost at grade 2 on the left side. Rhombox test negative. No cerebellar signs or involuntary movements. Uh, so coming to lab reports, uh, in
Uh,
April 2025,
Rani, if I may
yeah,
stop you for a while. On your examination finding, what is the significance of the cardiovascular system examination here, particularly in this case?
uh, sir, in this age group, there is a rheumatic heart disease can be present in 15 to 16 years of age, and there could be emboli. Uh, the emboli from the vegetations can have gangrene as a presentation. So I would like to see CVS examination to rule out any murmur or in vegetation.
Very good. And can you have a non-infective endocardial lesions given the differentials of your case?
Yes, sir.
And what are they called?
Liebman's axis endocarditis.
Okay. Do they often emboli, or I mean, is what is the nature, and what is one point that you can differentiate between a non-infective and an infective endocarditis?
Sir, Liebman's axis, they are usually tight. The sizes are small compared to the vegetation sizes in infective endocarditis, and usually they don't embolize. Um, and then there is no any fever in Liebman's axis endocarditis compared to
Yeah, but they could have because of their primary illness, say lupus patient, like in
yes,
this
sir.
case. The fever could be
Yes.
due to primarily the disease, and there could be this valvular thing. So you're right, most of the things, and also the valves, underlying valve is usually healthy in Liebman's sacs, whereas if you see a valvular destruction happening, then it is more suggestive of an infective endocarditis.
Yeah, okay.
In your respiratory system, you mentioned everything is normal. So this time around, there is the breath sounds are bilaterally equal because your scan had shown something suggestive
Uh,
of pleural effusion on history. So you mean by now everything is normal? The breath sounds are bilaterally equal, right?
yes, sir.
Okay.
On an
Good.
examination, I could not get any
Fair enough.
abnormal
Yeah.
findings.
Yeah. You can go ahead with the reports.
So, on lab reports in April 2025, before the patient came to us, there was bicytopenia, HB of 7 and WBC of 3,350. ESR was raised, and so that time sputum gene export was done. It was a negative, and patients was started on antitubercular therapy as per HRCT findings. And patient came to us in October. That time patient had again bicytopenia, HB of 6.9 and a WBC of 3,064, 640, and there was a lymphopenia. So in the previous report, patient had normal creatinine, LFT, SGOT, and PT were normal. Total protein were increased to 8.39, and CRP was negative, and ESR was 65. And again, the Suboxone gene export was done in 30th of September. It was negative. So, and further rheumatological investigation, We did ANA by immunofluorescent assay. It was 1 to 320 speckled and cytoplasmic pattern. dsDNA was done by immunofluorescence. It was a positive. C3, C4 values were decreased. Iron studies and ferritin were normal. APLA profile was negative. DCT and ICT were done, which was a pre-transfusion sample. It was 3 plus and 1 plus. Urine routine was normal. So we performed ANA blot. On ANA blot, there were multiple antibodies were positive. Uh, Mi2b-Cu were positive, whereas SSA, Rho52, centromere P, A and B, and ribosomal P were strong positive. Nucleosome were positive, and AMA-M2 was also positive. So further investigation, UAG, abdomen and pelvis, there was a borderline splenomegaly of 13 centimeter. UAG bilateral lower limb and upper limb Doppler was done. It was normal. 2D echo was normal. UAG local neck was done. It was suggestive bilateral cervical subcentimetric lymph node, likely a reactive etiology. Chest X-ray was done. It was suggestive of opacity in the left costophrenic angle. So this was the X-ray on presentation, and on the left costophrenic angle there was a opacity seen. So further we did HRCT test on the CECT abdomen. There were multiple centrilobular nodules, pre-inward appearance, representing bronchogenic spread of infection in left upper lobe. There were few scattered nodules in the both lung field consistent with the active COX. There was left basal pleural calcification, likely heel tubercular pleuritis, and mild hepatomegaly with periportal, peripancreatic, and mesenteric lymphadenopathy, likely reactive or infective. So this was the X-ray, CT scan done. On this film, you can see the whitish thickened area suggestive of a old pleuritis or the heel peritubercular pleuritis. And in this Siddhartha section, in the upper lobe, there were multiple nodules were seen. Uh, they were suggestive of a tree inward appearance representing bronchogenic spread of infection. So on further investigation, a nerve conduction study was done. It was asymmetrical sensory motor axonal neuropathy affecting both upper limb and lower limb, and electrocardiogram was normal. So coming to diagnosis, I would like to keep my diagnosis as a systemic lupus erythematosus with hematologic involvement, with mucocutaneous, musculoskeletal, neurological, constitutional, and digital gangrene, likely lupus vasculitis with I would also like to rule out drug-resistant tuberculosis in my patient because there was a significant childhood history of tuberculosis, and HRCT finding were suggestive of active infection, although we could not microbiologically prove whether it is a tuberculosis or any other infection. Uh, so further,
And in your list of investigations, can you go back? Did you mention about, or I missed it, the antiphospholipid syndrome workup? The APLA antibodies were done. Yeah, you
yes,
have
sir.
mentioned. Okay, APLA profile negative.
You,
Yes,
you haven't mentioned about 2D echo.
yes, sir. I have mentioned
Yeah.
2D echo is
Okay,
normal.
2D echo. Yeah, normal.
Okay. Are you surprised you saw a cytoplasmic speckled pattern with all your other antibodies positivity? Just go back. Speckled, cytoplasmic.
I think this is nuclear speckled and plus cytoplasm. I think
What would you have expected with the dsDNA, nucleosomes? They're all generally what pattern they should give.
Said nuclear pattern, homogeneous
So
pattern. Sorry,
nuclear pattern,
homogeneous
but how would you see it on the
pattern.
immunofluorescence?
Hom-
As a
homogeneous patterns.
homogeneous pattern. And this Mi2b
Homogeneous
antibody being
pattern.
positive on your blood, does it make you think that there was a myositis overlap in this patient? Like when you
Sir,
get this report in
clinical
hand, you're
examination.
obviously seeing everything, and then you see the Mi2b also positive.
Yes, sir. Sir, as the specificity of this antibody is very high, so but on examination, I could not get any component of myositis, and or there was no any skin changes as well. So I would like to keep in mind on further follow-up that and I'd like to check her muscle component follow.
Okay. Dr. Chengapal can add to this, but he had beautifully presented few cases with underlying tuberculosis and false positivity of myositis antibodies. And of course, here, given the background that there is already a connective tissue disease, MI2 being a nuclear antigen, I think with so many nuclear antigens coming positive, it can come positive even otherwise. So it may not be representing a true myositis here.
So why did we do a 1:320 dilution?
Sorry, sir.
Why did we do a dilution of 1:320? The recommendation is now 1:80. Hello? Hello?
Sir,
Okay.
hello, sir.
Yes.
In normal population, we can get ANA positivity. That's why we need to increase the dilution and see till what dilution we can get the positive titer, positive dilution, so as to increase the sensitivity of the test.
No, sensitivity means you should have a lower titer. No?
Specificity.
You want to pick more people, so you'll need lesser titer. And double stranded DNA won by immunofluorescence, not by blot.
Yes, sir.
Blot was negative.
No, sir. Actually, it came.
What is the role of doing double stranded? Yes, sorry.
So it is a specific antibody for lupus.
But what is the role of doing a immunofluorescence now in the current era? What is the role of doing a double-stranded DNA immunofluorescence? How is it done? What is the substrate?
Sir, it is done by using a microflagellate Cryptridia lucili.
Yeah.
Good.
So nowadays we prefer ELISA over immunofluorescence assay for DSDN. But actually it came in the ANA blot report, so we didn't do again with ELISA method.
The ANA is negative, no? Blot is negative.
No, sir, I mentioned in the this side, but in ANA blot also DSDNA came as a positive.
Okay. So as sir was telling, MI2B alone when it is coming, just be careful. Usually this antibody complex comes together. It has to come together. MI2A and MI2B both should be positive to say that it is truly positive. But we see in our myositis profile so many times either one of them comes positive. But in this case, we can take it as maybe either a false positivity because of tuberculosis, or we can just ignore it.
Okay.
Rani, why is the ferritin so important here? You have specified iron studies with ferritin, casual or something very important here?
So ferritin is a marker of inflammation. So during inflammation, it should rise. And when the patient has persistent fever and cytopenias, so I would also like to rule out the macrophage activation syndrome in her. So, as ferritin is a most sensitive marker for mass, if there is a more than the ferritin is increased, it is suggestive of a macrophage activation syndrome.
And what other lab parameters would you take help of?
Triglyceride, there is a triglyceride are raised in macrophage activation syndrome. CRP is raised, and fibrinogen is decreased, ESR is decreased.
And why is the triglyceride raised? Isn't it one of the odd things? You can understand LDH and CRPs and other things. It's just something from the lipid pathway become important for macrophage activation syndrome.
There is increased of in the synthesis of triglyceride from liver.
In fact, it's the other way around. Actually, the uptake of triglyceride from the blood is inhibited by the cytokines released by the activated macrophages. So that is why in the blood you see very high levels of triglyceride. You can verify this, but to the best of my knowledge, it's not the increased production, it's rather the decreased uptake. So that gives rise to the higher levels.
Okay, sir.
Okay. Uh, Fine. I'm
Any
still surprised that with so much of pleural this thing, you still got the breath sounds bilateral equal. I'm not sticking to just that, but there was a lot of pleural reaction and pleural this thing. So maybe clinically, if you corroborate, possibly there should not be significant breath air entry that side. I think you can go ahead with the treatment part because we are getting late since we started late. But we may have some questions again based on the treatment part.
So, coming to treatment, we gave injection methylprednisolone 250 milligram for 3 days, followed by oral prednisolone 25 milligram daily as a 1 milligram per kg per day dose, and started with tablet mycophenolate mofetil 500 milligram BD, tablet hydroxychloroquine 200 once a day, tablet aspirin 75 mg once a day, and tablet citran double strength alternate day. After the opinion from pulmonologist, as patient is currently on 6 month of AKT, she was advised to continue same for 1 more month, and patient is posted for BAL after the 1 month of AKT and the repeated radiological result to look for the repeat radiological resolution, and, and advice for PRBC transfusion and the wound care. So, that's
Did you think of cyclophosphamide as one of the option, given
yes,
the
sir.
neurological manifestation of mononeuritis and uh, the digital gangrene, possibly vasculitis is what you mentioned. So would you want to treat this patient with cyclophosphamide or you're comfortable with mycophenolate?
Yes, sir. Actually, my first, given the nature of the disease and the organ involvement, my first choice would be cyclophosphamide in her. But patient was, because there was a active infection on HRCT, and we could not get any microbiology evidence of tuberculosis. So that's why we actually started on mycophenolate rather than cyclophosphamide.
Very
Uh,
good, very well answered. And what is the dose of mycophenolate mofetil in pediatric age group? She's 16, right?
yes, sir.
Yeah, adolescent. So is there any
Three,
difference or the dosages are calculated the same way?
sir, it's 3 to 5 mg per 2 to 3 mg per kg.
No, that would
no,
hardly come to, even in a 70, that would come to 200, your best dose.
is
So
it
it's
per kg
actually
or per meter square?
it's actually about 30 to 40 milligrams per kg per day, and most of the recommendations go by 600 milligram per meter square twice in a day. So it comes to 1,200 milligram per meter square in pediatric. Of course, the ceiling still is 1 gram twice a day. But particularly if you're dealing with pediatric patients, then you would go by the body surface area as the dosing. So you should be aware of. I'm just mentioning that if you get a pediatric thing and then the dosages differ. So if you were to choose azathioprine here and the patient could afford, would you do any test prior to starting azathioprine?
Yes, sir. TPMT mutation studies and NUD15 gene studies I would like to do in patient before starting azathioprine.
And if the patient
Uh,
could afford only one, what would you choice?
TPMT. NUD15 is not TPMT.
Sorry, I didn't hear you.
NUD15.
Why so?
Uh, because it is a gene involved in the and more commonly involved.
More commonly involved where? With azathioprine or
I think in our commercial labs it is involved.
no? So that's not the answer. Basically, studies have shown that although in general it is only 15 to 20%, but when it comes to Asian population comparison with the Caucasians, TPMT is more prevalent there, and therefore, if you have to choose one, probably you'd still do ideally, of course, both, but annuity becomes more important in the Asian population. Okay, we still in practice, if the patient is affording, do both. We don't choose only the annuity because TPMT also is present. So, but that was just an academic question to know that it is more prevalent in the Asian population.
Okay.
In the same line, if patient can't afford both of the test, how would you give the other type in dose? What will be the for poor patient?
Poor patient, so it is 2 to 3 mg per kg.
Will you start
So I
immediately
would
on that dose
start,
or
no, sorry, I'll like to start with 50 mg OD, and then I would like to monitor the CBCs every 2 to 3 weeks and look for the cytopenias. And after that, I would like to increase to uh, BD dose and then monitor CBC every 4 weeks.
only CBC or anything else? Or
And
liver
LFT,
function?
LFT is also.
Anything to do with the steroid dosages here, given that the patient is also on the anti-tuberculous treatment right now? What is
Yes,
your
sir.
concern and
Actually,
consideration?
anti-tubercular drugs, it increases the metabolism of steroids. So, ideally,
Which
in patients who are on anti-tubercular drugs, the dose of steroid should be a little higher
For
as
the
per the
expected response. Yeah. So
norm,
which
whatever you want to give for that expected
uh, expected
treatment,
as
you
per
want
the,
to
yeah, yes,
keep it higher. Yeah. Good.
which anti-tubercular drug?
rifampicin.
Would
It is
there be any
a
challenge
rifampicin.
in this transfusion? You gave transfusion. You mentioned your DCT and ICT both were positive. Is there any concern when you just order for a transfusion? Is there any specific precaution you need to take?
Sir, there is alloimmunization in patients who have antibodies. So if there is a life, like the HB is low and life threatening, so in that patients, you ideally we should be transfused in patients of autoimmune hemolytic anemia. Otherwise, it can be managed with drug medical management. So as and when required, only I would like to give the patient transfusions.
And out of the direct and the indirect Coombs test, what would worry you when you're transfusing?
Uh, it is a direct.
Sure.
Yes, sir, because of antigens.
Okay, you can check, but it's probably the indirect
Indirect.
Coombs test because then your hemolysis chances to the transfused RBCs are going to be much higher.
Oh,
And
okay.
probably that's also one of the purpose why sometimes both are done. Otherwise, you would know with a DCT only. All right, Deepak, you would also have to
Yes, sir.
tell us when we need to
Yes, sir.
stop.
We can conclude. If you want
Because
one
I
or
don't
two
want
questions, we
Chengappa
can
to be.
conclude.
Uh,
Yeah.
Cyclophosphamide regimens. Just last maybe question. What
Uh,
cyclophosphamide regimens you know?
so there are two regimens, Eurolupus and NIH regimen. In Eurolupus, it is a low dose regimen where we give 500 mg every 15 weeks, 15 days. And in NIH protocol, we give zero point 0.5 to 1 milligram per meter square every uh, zero point 0.5
0.5.
or every, sorry, 750 milligram per meter square every monthly.
How many doses?
every monthly six doses, 6 pulses, and after that maybe 3 monthly for a maintenance.
So, Rani, I think you have presented very well and you have done your homework. You have made attempts to read everything. You're quite aware, your first year. So
It's
you
the
have done
first
well.
year.
And I
That's
think the take home from the case is while dealing with an autoimmune disease, always be vigilant for infections, whether it is macrophage activation syndrome coming in a case of lupus, and you actually then realize that it's a cytomegalovirus infection, or whether it's a gangrene in a case of autoimmune disease and you miss out an infective endocarditis and burn your fingers, or in this case, there could be a potential multi-drug resistant tuberculosis, and so many more. And in fact, recently I had one case where there was gram-negative sepsis, which was responsible for the persistent drop in the complements, because that's the other reason why complements keep dropping. And it was always a challenge, keeping the lupus activity, because C3CRP would probably be one of your important ways to go by, but both were not helping. So that's what is, I think, the important take home from the case.
Giri sir, Chengappa sir, any feedback for Dr. Rani?
I think she has presented quite well. Like she's first year, and it was
Yes, sir.
impressive presentation.
Yes, sir.
Yeah, actually, great job.
Okay. Okay, thank you, Dr. Rani, for such a good case discussion. And after this, we have Dr. Chengappa sir, who is a consultant at RheumaCare Mysore, and he has over 80 peer-reviewed publication, including the well-known work on drug withdrawal in SLE trial, and he has extensive work in myositis as well. And he's a former associate professor at JIPMER Pondicherry. He'll be going to talk on endgame in lupus therapy, when and how to withdraw treatment in SLE remission. And with his extensive research, we are looking forward to learning from his experience. So over to you, sir.
Yeah, good morning, everybody, and thanks for joining in on this Sunday afternoon. Dr. Nilesh called up and told that he wants to discuss endgame in lupus therapy. And we thought, how would he go about this? So, yeah. So let's start off with the story. This is my patient. I call her Lupakshi. Yeah. So this is the Miss Lupakshi, who is a 24-year-old girl, and she comes to the clinic and asks, "Okay, doctor, we have known each other for about 3.5, 4 years. Now, can I stop medicines?" So I'm sure this is a common scenario in most of your clinics, where you have a long-term lupus cohort, people who come walk in every time they want to know if their medicine can be reduced or stopped. But then we did a flashback. About 3.5 years ago, she was admitted in our ICU in a very bad state, had severe lupus nephritis, multi-organ involvement, DAH. We had to give her everything that was possible and pull her out of that state. And now she is in remission. Fine, great. So the question is, do I want to really remove the medicines that has kept her safe for about 4 years now? And how we try to answer this question in any case of lupus or any other connective tissue disease mostly is, do we really want to taper? Why do we want to taper? And if yes, if both of us are convinced, then what do we want to taper? And then when do we want to taper? And finally, how do we want to taper? So I think these 4 questions will be the way I will discuss the whole presentation. This is the way we all think when a patient comes. So I'll take it ahead from here. And please feel free to ask questions and participate in between. So coming to why do we want to taper, I was a little lazy. I asked Perplexity to pull up all evidence and give me relative risks for each of these drugs, what it can cause, because we know it will cause, and we also know that it won't cause. So if you look at the data, the literature says that yes, a lot of neoplasms are possible with long-term azathioprine use, mycophenolate use, and methotrexate, cyclosporin, and steroids. We all dread of because methotrexate. Some say it will cause liver toxicity. Some new publications say it will not cause liver toxicity. Some say it will cause lung fibrosis. Some say it will not cause lung fibrosis. Some say there will be bone marrow suppression. Some of them say there is no bone marrow suppression. And cyclosporin, we know that at high doses usually compromises renal function. And steroids is a nightmare for clinicians, rheumatology clinicians, especially trying to explain to the patient if steroids are useful, useless, harmful, harmless, whatever. So I think we know all these things, but we are really not convinced that this is the real truth when it comes to real life evidence. So by withdrawing drugs, basically what we want to achieve is we want to prevent side effect for the patient. That is the long-term side effect. We want to prevent repeated blood tests. The logistic issue where patient has to come to you every 3 months, get a urine, blood, whatever test done, and sometimes get a fundus opinion done every year. So all these things we want to avoid for the patient. In the same flow, this is going to benefit the patient in terms of monetary savings also. And finally, we want to feel good. Let's be honest. When we try to taper a drug and stop it, and patient is doing fine, it is an ego boost for us, and patient is also going to feel good. So these are the real reasons why we should think of trying to taper these medications, and the data shows that there are some potential long-term harms of these drugs. So the question next is, what do we taper? Yeah, what do we withdraw? Hydroxychloroquine, because it's a harmless drug, we think it is not very useful sometimes. It causes a lot of pigmentation. Patients are not happy. And the investigations that is used to monitor hydroxychloroquine toxicities are really expensive. The patient has to undergo fundus examination, undergo OCTs, and a lot of newer ERGs and stuff like that. And this significantly increases the burden for the patient. So, but we all know as the practicing rheumatologists that this is not a good option, especially for our patients with lupus. The first evidence was shown by this fantastic Canadian group where they tried to withdraw. In one arm, they withdrew hydroxychloroquine, and in the other arm, they continued hydroxychloroquine. And you can see the flare-free interval or proportion of those without any major flares was significantly different between the two arms, the dotted line being the placebo arm and pointers. Yeah, the dotted line being the placebo arm and the hard line being the hydroxychloroquine arm, where using hydroxychloroquine resulted in less flares. So this was clear that in a patient who has achieved remission, if you remove hydroxychloroquine, possibly they are going to flare. But you see, this study was done in 98 and not many drugs were used very commonly in lupus. So I thought that we should also look at recent evidence. So when I'm giving all these expensive mycophenolates and tacrolimus and possibly rituximabs and steroids, does still this small cheap hydroxychloroquine have any role? So this is the data from a Chinese group which is recently released. The study is called PRESS study, which means prediction of relapse risk in stable SLE after glucocorticoid withdrawal. So what they did, this is a cohort study where they withdrew glucocorticoids on patients who were doing fine, and they found that when they were off glucocorticoids and off hydroxychloroquine, that is the pink or red line, they had a lot more relapses. And when these patients continued to take hydroxychloroquine but still managed to withdraw glucocorticoid, their flare was similar to those continuing both these medications, that is hydroxychloroquine plus glucocorticoid. So this study concluded that, yes, in patients who are stable, in SLE patients who are stable, and if you want to withdraw glucocorticoids, actually having them on hydroxychloroquine benefits. And this is another study from the APLAR group where they saw that use of anti-malarials prevented any overall flares as well as major flares or severe flares. So it is a no-brainer now. So old studies, new studies, everything seem to echo the same sentiment and same data points. They say that do not withdraw hydroxychloroquine at all from these patients if you want to really taper off medications. Then the next logical question would be, okay, let us withdraw glucocorticoids because this is what most of the guidelines have been telling us. Glucocorticoids will have to be withdrawn first, and then other DMARDs. So possibly this is the next logical step because we know it is so bad. Glucocorticoids are so toxic. It will destroy your bone. It will cause cardiovascular risk. It will cause diabetes, that and this. So this might be a logical option. So I will not bore you all with a lot of data here. Luckily for me, there was a meta-analysis that was put out this year. So what they found is very interesting. So I'm sure most of you are able to withdraw glucocorticoids in your patients, at least a fraction of them. Yes, no? How many yeses? Nobody yeses? No yeses? Okay. So I think in clinical practice, we are able to kind of taper off glucocorticoids. Yes, so Kaveri could do it. A lot of people are able to withdraw glucocorticoids in patients who are in remission. But if you see the data, it tells us a different story. So what it tells us is, if you see the analysis done from randomized controlled trials, which is considered to be the gold standard of any evidence, there we see that withdrawing glucocorticoids results in a lot more flares. Whereas if we see data from, if we see the data from the cohort studies, that is the below part, the second part of this chart, we see that withdrawing glucocorticoids and continuing glucocorticoids have got similar effect. It does not really cause flares. So this is quite confusing. And I'm sure this cohort data is what gels with most of our thoughts, where we are able to withdraw glucocorticoids in some of our patients. Let's not say most of our patients, in some of our patients at least, and come to a halt. Only I think our Rudra Goswami, who did a study from IPGMR, only his study kind of said that withdrawing glucocorticoids resulted in more flares. So there is this dilemma now. So RCTs are telling one way, the cohort studies are telling another way or another kind of an evidence. So what I try to do is take a cumulative evidence and see from RCTs, okay, fine, you have said that they are going to flare. What is the amount of flare? How many of them are likely to flare? So what we found is the number of people who are going to flare in the first year is somewhere in between 25 to 30%. So 25 to 30%, almost 1/4 of the patients in most of the trials have flared when glucocorticoids have been withdrawn. But then why was the cohort study telling us a different story? Of course, there are a lot of bias. When we see a cohort, there are drop-offs. We don't withdraw glucocorticoids when we think it is not good. So there is the investigator bias and a lot of things that come in. But there is one important lesson that we can learn from the cohort studies. That is, again, by the Daphna Gladman and Urol's group from Canada. What they did was very smart. Luckily they have 1 milligram prednisolone tablets there, which we don't have in India. What they did is once the patient reached a 5 milligram dose, every week on one day, they tried to reduce the dose by 1 milligram. So the first week, they gave 6 days of 5 milligram and 1 day of 4 milligram. The second week, what they did is they gave 5 days of 5 milligram and 2 days of 4 milligram and so on till they reached the 7th week, where almost every day they got about 4 milligram. Once the patient reached 4 milligram, they went to the next dose, that is 4 and 3, then 3 and 2, then 2 and 1, and then 0. With this, they could taper off steroids in almost all the patients in about 18 months. So here adjustment must be made for clinic visit frequency, withdrawal symptoms, and patient preference, tolerance, all these things. But the lesson that we can learn from this fantastic paper is that if we want to possibly successfully withdraw it extremely slowly, not the usual way where we bring it down to half in every 2 weeks or every 4 weeks. Instead, take your own sweet time. Let the patient know that you're making attempts, and you should know that you're making a conscious attempt, and withdraw these medications extremely slowly. The next question is, okay, can we withdraw immunosuppressants? So this was a crazy idea that we got while we were dealing with the COVID pandemic just before that. So I was working in Jitwad, and what happens there is patients come, then they default. And there is a subset of patients of SLE who would come back and would look still normal. We had given them 3 cycles of cyclophosphamide, then they have disappeared. They come back after 6 months just to show their face, and they seem to be normal. And when we looked at the prescription, what they are taking, they continue to take that low-dose steroid and hydroxychloroquine because they are cheap. And the other group was there which stopped everything, just went cold turkey, stopped everything, and came back with very, very bad flares. So obviously, this is a biased finding, this is an anecdotal finding. And then we started to think that why should it be that, when we have a risk of having a flare of about 25% while we stop steroids, why isn't it possible to bring down the immunosuppressive dose? So that is why we designed this trial, and Dr. Aishwarya, who was there with us, ran this trial fantastically despite COVID. And we managed to recruit 58 patients in each arm, 59 patients in each arm. It was a randomized control trial. One arm where we withdrew steroids over 3 months, and the other arm we withdrew immunosuppression over 3 months. So from the date of initiation of withdrawal, we started to count the events. And at the end of 1 year and at the end of last follow-up, minimum being 2 years, is what we took. And what we found was very similar. When we withdrew glucocorticoids, we had a flare of about 30-31% at the end of 1 year. But when we continued the low-dose glucocorticoid, that was 5 milligram or lesser, along with hydroxychloroquine, but withdrew the immunosuppression completely, we had about 20% flare in these patients. Even the severe flares were not very high. It was about 6%, 7% in glucocorticoid withdrawal. Then we continued open labelly, we continued these patients, we followed up these patients, and at the end of 2 years, and almost some of them almost reached about 3.5 years, what we found was this difference continued to persist. There was more flares when glucocorticoid was withdrawal as opposed to immunosuppression was withdrawn. So this was a non-inferiority study, and we could say that withdrawing immunosuppression was non-inferior to withdrawing glucocorticoid, and we could not prove superiority because the number of events were not as much. But the main thing, what we have to see is, by the end of last follow-up, almost 40% of the patients, if you withdraw the drug, would flare. Yep. Then the question, now coming back, we are putting about 1/3 to at least 30 to 40% of the patients into the risk of flare by withdrawing the medications. So what was our goal mainly? Our goal was to decrease medication side effects, decrease steroid dose, decrease money for them, decrease sampling. So if you see this graph, if you see the survival analysis, you can see that their flares start as early as 100 days. So in 2 to 3 months, they start flaring. So that does not mean that we have a leeway period where we cannot investigate them or where we cannot follow them up very closely. So, counterintuitively, if you are withdrawing medications, I think we should have them come for follow-up more often, do their blood tests and urine tests more often. So our logic of having less blood tests and spending less money may fall flat if we are really withdrawing a medication, and we have to be prepared for that, and we have to communicate the same to the patient. Another thing, what we saw is, if somebody flared, they ended up taking excess prednisolone by about 2.38 grams. Whereas if they did not flare, they had about 0.27 grams of steroid per, that was given throughout the study duration. So what this says is, by trying to save that 1 or 2 milligram of steroid, we are putting them at a risk of a very, very high dose steroid if they flare. And this is true when they had multiple flares, they had even higher dose of steroids. So by define, are we really preventing the side effects? I am not really sure. Are we preventing repeated blood tests? Not at all. In fact, if somebody is in remission, we are more relaxed and we could, get their blood and urine done once in 4 or 5 months. But if we have decided to withdraw something, they better come back every month initially. And once we know that they have stabilized, again go back to the 3 months. So we are not preventing repeated blood tests. Are we saving money? Yes, we are saving money to some extent, but if they have a flare, then everything is lost. And because we know in India, there is a lot of out of pocket expenditure whenever there's a hospitalization. And finally, do we really feel good about this? At least after this study, we didn't feel good. We had second thoughts before, having this discussion with any of the patients. And the perceived risks that we had initially thought of, are they really true? The hydroxychloroquine causes retinal blindness. It increases, all these things. So we know that these risks are actually minimal if we are cautious in using hydroxychloroquine, not over treating them, giving them 5 milligram per kg dose. And the risk is about less than 1% at 5 years and less than 2% at 10 years. I think this is a small risk we can take as opposed to getting admitted again and again. Steroids also, we'll talk about steroids. When this is the APLA study that came up, which said that if somebody is on a dose between 0 and less than 5 milligram of steroids per day, of prednisone per day, their overall damage accrual is not high. They don't accrue damage as high as those taking more than 7.5 milligram steroids. So it is, I think, 2 or 3 milligram per day kind of a dose is going to do them more benefit than a lot of harm. Then, so what we could conclude is, okay, there is no one size fits all. No, we have to discuss with the patient. We have to see their socioeconomic status, their compliance levels, our confidence level in the patient, and then decide on tapering the drug. And then we decide which one to taper. If somebody is on mycophenolate, very high dose, not able to, buy that, probably we can reduce the dose. De-escalating mycophenolate there would be harmless. It would actually result in saving more money to the patient and without causing much of a harm. So the next question would be, okay, you said 30 to 40% of them relapse or flare. Is there a way we can predict these flares? Is there a subgroup of patients who really flare? So from our study, what we found is that only low C3 at baseline before tapering, if they had low C3, then probably they had a higher incidence of flare. And this was the same thing that was shown in a meta-analysis that was published this year, where they didn't include our study in this meta-analysis, so it is not biased. So we find that low C3, low complements, or if they are serologically active, that means if they are low C3 or C4 with high double-stranded DNA, then their chance of flaring is little higher. So in these patients, let us not try to stop glucocorticoids or any other drugs. Then from the same study, what they found is none of the domains actually cause a lot of flares, except if there is a mild ongoing arthritis domain, then it might cause a flare. So try not to withdraw the drugs. Another thing that was seen is the speed of taper. So the last column of blocks that we see here, which shows Doris LLDAS, no LLDAS. So here, just before that, if you see the slow taper positive with hydroxychloroquine, these are the patients who have the least number of flares when you withdraw any of the medications, especially the glucocorticoids. So what we can learn is if somebody has a low complement or is serologically active, let us not do this exercise of trying to taper off medicines. And if we want to taper, let us go extremely slow. Then there are other predictors of flare. The kidney biopsy is a fantastic indicator that these patients are going to flare, especially if they had an underlying lupus nephritis. So this was the initial study that was published in 2018, where they saw about 76 patients. They were in remission for 12 months. They did a renal biopsy again, and they found that doing a renal biopsy, and then if the activity score was less than 2, if they started to withdraw the medications or glucocorticoids, these patients did not have any incidence of end-stage renal disease, or they had very low incidence of severe renal flares. Similarly, this was another study in 2022 where they found that if somebody had complete renal remission and had histological remission, that is seen in green, the 40 numbers, when you withdrew their immunosuppression treatment, their rate of flares was way lesser than those who did not achieve this histological remission. And even we had a similar finding, because we had done renal biopsies before we withdrew the medications. And we found that if anybody had activity index of more than one or more than one, then these patients are 100% going to flare if we withdraw any of these medications, irrespective of immunosuppression, irrespective of glucocorticoid. So histologically, if they are zero, activity index becomes zero, then there is a high likelihood that these patients are not going to flare. But having said this, what we found in this paper is that though the renal activity was zero, these patients can still have extra renal flares, which are not very severe though, but renal flares can be predicted by doing a repeated renal biopsy. I'll deviate a little. All of us are clinicians. It's very difficult to get a biopsy. And you might ask me that, is it so different from a clinical finding? Means if I do a very good clinical assessment, do a 24-hour urine protein, do complements, all these things, and then decide, does it really not match with the clinical histopathology would be a question, which the first thing we tried to address in our first study of about 333 biopsies, it was a retrospective study, which we did. And we found that the specificity. So clinical parameters, what do we mean by clinical parameters? Anybody with renal dysfunction, anybody with proteinuria more than 0.5, that is 500 milligram, anybody with hypertension, anybody with active urinary sediments. If these were there, if any one of the parameter was there, to detect a proliferative lupus nephritis, it was highly sensitive. It was about 96%. But you see the specificity, it is very poor. So what I mean to say is that histopathology would supersede these clinical manifestations. In most of the times, we could not really identify the non-specific things, and we would miss out on the active lesions. And then second is, if all the 4 parameters were present, then the specificity went up very high, and we could really identify those proliferative lupus nephritis, but that was at the cost of a sensitivity. So what I am trying to tell here is that our clinical manifestations that we usually see in the clinic, that is serum creatinine, proteinuria, hypertension, active sediments, these are not true reflections of the histopathological process. This was also seen in the previous 2 papers that we discussed. I'll just highlight it for you, where the histological remission, the clinical remission was in 51 patients, but histological remission was only in 40 patients. About 11 patients who had clinical remission did not have histological remission. Same thing here. All the 76% patients who were enrolled into this study had clinical remission for 12 months. But when they did a biopsy, they found that out of 76, 21 had histological activity which was present. So almost, what it says is that whatever we measure clinically is not enough, especially if we want to take a risky decision like tapering of steroids. So doing a protocol biopsy, if the patient had lupus nephritis, is a must before we make this decision of withdrawing steroids. Any more biomarkers? These are all fine. Any more biomarkers? So I try to search this in terms of pre-CAR T cell therapy and post-CAR T cell therapy, because I think CAR T is the only thing that has given us sustained long-term remission, at least anecdotally. So I try to look at their signatures and before that, and what we found is yes, anti-double stranded DNA complements. If they all normalize, then yes, it might you can still think of reducing the medications, and chances of flare would be less. Something called endothelial progenitor cells, which we usually don't do, but it strongly associates with the definitions of remission. This one that is being done now quite routinely across places, interferon signatures. If there is a reduction or absence of interferon signature as opposed to beginning. But the problem is we need a baseline interferon signature for this to say that if it has reduced or not. If that goes down, then probably these patients are in deep remission. So clues from CAR T cell, I got the same clues actually. Suppose somebody had lot of antibodies, and when you repeat all the antibodies, everything becomes negative except ANA, then possibly you could think of withdrawing the medications. That is, autoantibodies will disappear. Then interferon signature gets suppressed. Then complements will normalize and all the cytokine will reduce. So the cytokine reduction and interferon signature suppression both will need a baseline sample, which is not very practical in our situation. But I think if autoantibodies that were positive before have all become negative now, then that is a good measure to say that somebody has gone into deep remission, unless they are not CKDs now. And there are other immune cells also that can tell us that the same thing gets translated. This is the pathophysiological basis that more naive cells are present there, less of memory cells are present if somebody is in deep remission. So how do we think of withdrawing? So when can we think of withdrawing? Like practically, what do we do in a clinic? Now, if somebody has achieved a DORIS remission or LLDAS, lupus low disease activity state, if it is DORIS, which means that clinical SLEDAI is 0, it's only clinical SLEDAI. Physician global assessment is 0.5. Antimalarials are allowed and maintenance of immunosuppression and biologicals are allowed, and prednisolone should be less than 5 milligram, equal to or less than 5 milligram, and no other clinical disease activity at all which cannot be measured by SLEDAI. If that is there and the patient has achieved it for 12 months and there is no lupus nephritis, then we can think of withdrawing the medications. Or if somebody has a SLEDAI of less than 4, SLEDAI 2K of less than 4, with a physician global assessment of less than 1, with all these things being allowed, even then, if this condition has been maintained for 24 months, that is 2 years, even then we can start thinking of de-escalating the therapy. But if somebody has a lupus nephritis, we would need a minimum therapy duration of 36 months, preferably 48 months. That is 3 to 4 years. 3 to 4 years on maintenance, then do a repeat renal biopsy. If the repeat renal biopsy has been inactive, that is the activity index is about 1, then we can start thinking of doing a drug de-escalation in these patients. So what can we deduce? What can we deduce is we have to achieve remission. We have to assess risk of de-escalation. We have to somehow have a withdrawal strategy, and then we have to aggressively follow up these patients post-withdrawal. So what is the remission? It is DORIS or LLDAS, at least 24 months. Do a protocol biopsy for lupus nephritis. Make sure hydroxychloroquine is being continued in this patient. If there is a contraindication, then don't even try withdrawing or stopping. Do a risk assessment, do serological activity. You can do interferon signatures if you had before. Do autoantibodies if you can. Then if patient is a male and very young patients, try to avoid. Make sure that they are into their 40s before you try to withdraw, so that the flares become less. It is known that with age the flares become less severe. And then decide on immunosuppression versus steroid. Both are good. It's not steroids are very bad and you have to just withdraw the steroid. If you can achieve a steroid dose of less than 5 milligram, 2 or 3 milligram effective dose per day, then that would be more than enough, rather than trying to stop everything and putting them at a risk. And gradual tapering, not the RCT method of tapering. Go the cohort method of tapering. Take your sweet time, maybe 12 months, maybe 1 year. If you're bored, you can let me know. And finally, post-withdrawal, do regular labs, serologies, and at least first year at least you have to do 2 monthly labs and follow up the patient aggressively. So the ghost of the past, Lopakshi, what I'll tell her is, you're too young. I will buy more time. Maybe we'll do a kidney biopsy in 3-4 months and decide. I'll bring down your steroids for sure to less than 5 milligram. Maybe remove one of the MMF, make it 1500 milligram per day if you are able to continue, and ensure continuation of hydroxychloroquine. But in short, what I'll do is taper, but not stop. But everything will change if she plans to get married or plans a pregnancy. Everything is going to go out of the window and we have to get back to the drawing board again. So this is a quote that actually interested me while I was preparing for this presentation, that the real world is a process and the knowledge is always an unfinished business. So we keep gaining knowledge as we do these things with our patients, as we talk to our patients, as we gain the trust of the patients and trust in what we do. So I think it is a process. Let us not look at it as an end game. So the end game in SLE isn't drug-free remission, at least not today. Okay, we need some drugs to maintain them. For now, we can only say that we can probably de-escalate. But with what CAR-T is being able to do, at least in those anecdotal cases, field might be shifting very fast. And what seems to be cautious today might become obsolete tomorrow. The whole presentation might be obsolete tomorrow because you give CAR-T and just stop everything. So we don't know what is going to happen. Let us be hopeful and optimistic. And this is our wonderful team from JIPMER. I know everybody there, the staff, support staff, all the faculty, all my residents, and it was a great team there. Thank you so much.
Hi, sir. Thank you very much for such a lucid presentation. And you almost covered with every question that pops in mind. So let's take some of the questions there are in question. So Dr. Madhuri has asked what was the duration of clinical and serological presence of patient included in the your.
So we needed a 3-year minimum, minimum of 3 years having remission before we randomized them.
And was protocol biopsy a mandatory criteria at inclusion?
We did a protocol biopsy, yes, for everybody with lupus nephritis.
And was the median EAF protocol biopsy done in the study?
Yeah, it was all median. What I've told is median only. Yeah.
Okay. Dr. Kaveshri has asked, in patient with newly diagnosed SLE treated with upfront rituximab, what are the reported deep remission rates and how does early B cell targeted induction affect steroid tapering? Is there any data on this?
So only I think we had this data from combination of rituximab and MMF. The study did not continue, but about 50 patient data was there, which said that it had a lot of steroid sparing effect. I think it's an interesting concept which are being explored across centers now. That's what I said. Whatever we discussed might have become obsolete by now. But upfront aggressive treatment with deep B cell depletion, at least in purely autoantibody mediated lupus, could be a very good avenue to actually explore.
And what is your protocol for tapering or discontinuing rituximab maintenance in SLE? I mean, after how many maintenance cycle do you consider switching to alternative immunosuppressive or continuing with low dose steroid?
So unless the patient cannot buy it, there is a adverse effect or there is severe hypogammaglobulinemia, I would rather continue rituximab low dose. Because that is the only, because whatever I have used is for people who are refractory. I have not used upfront and I don't have experience using upfront. So when we say somebody is refractory, that we also say that they have failed the other treatment. So I wouldn't be very brave enough to put them back on the same treatment. So unless there is a contraindication, I would continue it. Say 3 years, then 5 years, then the same thing what we do with rheumatoids. So
Yes.
yeah.
And now there is a Defcort 1 mg tablet also available.
Yes.
Yeah. So we can consider when
Yes.
tapering down. Any other question anyone wants? So, in your private practice, like, do you consider now renal biopsy while stopping the therapy, considering the
No, I'm not still there. I'm just 1 year into private practice. So you should tell me.
yeah.
I think Dr. Sunil can
No,
tell me.
even I have not tried Dr.
Yeah.
Sunil sir or Girish sir.
People are
And there are
they don't like to
there are,
do
Yeah,
too many investigations.
correct.
yes.
So for biopsy, they usually are not ready for do that.
Right. But I think we should give them a choice
Yes. I think,
Yes, sir.
because the data is really strong to say that that's a very good predictor. And if we are taking such a big risk, I think we should give them that option and have. Finally, it is shared decision making as we put it.
yeah. Very nice talk actually. One important topic actually.
Thank you, Dr. Krish.
So, should we conclude, sir? Yeah. Okay. Thank you, sir, for such a nice presentation. Okay,
Thank you.
we can stop. Okay.
Gently,